Rajat Fetal Medicine Award, POGG 2019, POGG Young Author Award for the Best Paper Publishing, JOGA in 2008, Best Paper Prize.
She is the Vice President elect POGG 2024, Chairperson Clinical Research Committee POGG 2016 to 2018, ICOG Governing Council Member 2021 to 23, National Coordinator, UNICEF, POGG, PCA, and Meda POGG, PG Program, ISA Gurukul Program 2022 to 23, and Series Conveyor ICOG Journal Club and ICOG Certificate Course 2022 to 23, WHO Southeast Asia Region MDSR India Member, Past Secretary Trichy OG Society, President Mental Hygiene Management Consultant 2018 to 2020, and Joint Secretary Justice India Association. I welcome you, madam.
Thank you so much, Pradhan. Thank you so much. Thank you, chairpersons, for the kind introduction. Being in Kanjivaram Society, as I said, it's as Umayyan said, Poonda Veedu. So I went back to Trichy, but I'm initially from Perindulathur. My in-laws have a residence here. Thank you so much for the opportunity. And as Chinmayi said, I was also flabbergasted when they gave this topic of crack the codes. And I asked Anit, are you taking revenge on me by giving me this thing when we don't have codes in India? Do we respond to emergencies as codes? We just say, Kupudu, order, and we run. That's the way our codes work. But we need to know how the rest of the world works when it comes to codes. And I think it's time that we have codes for ourselves. அதாவது எந்த நேரத்தில் எப்படி ரெஸ்பாண்ட் பண்ணணும்னு நமக்கும் தெரியணும், நம்ம நர்ஸ்க்கும் தெரியும். இல்லாட்டி தளர்ந்த கோழி ஓடுற மாதிரியே ஓடுவாங்க, சுற்றி சுற்றி வருவாங்க லேபர் ஓடலாம். ஆனால் ஒரே ஐவி செட்டை 10 பேர் எடுத்து கொடுப்பாங்க. ஆனால் எடுக்க வேண்டிய ஆக்சிஜன் யாருமே எடுத்து கொடுக்க மாட்டாங்க. கெஞ்சணும், கொண்டு வாயா, ஓடுவாயா. ஸோ ஐ திங்க் வி நீட் சம் கோட்ஸ். அண்ட் thank you scientific team. I think you took me as an advisor and then gave me a topic which will crack me also. Thank you so much. Let me go on to the top. These are coded messages announced over the public address system of a hospital, and you have to mention the location of where it's happening. There may be 2-3 labor rooms, there may be an operation theatre working, and you have to mention the location of where you want the people to assemble. These are used to convey essential information quickly and with minimal misunderstanding to the staff. And the staff ku puriyano and the code edukaganu and adu paadukku vandu tea kudichirukom. So she has to understand what the code means, and you need to prevent stress and panic among the visitors. Neenga paadukku code blue konna anga irukka attendant will run away. He will take the patient also along with him. So make sure that everybody understand what that code means. And it has to be like you have to give the location also. It has to be like code red and pota, 2nd floor, corridor 3, room 212. You can't just mention one, say code blue na ellarum vanduruvaanga nenikadinga nichchama namma staff vara. Pakkathu hospital ku kuda vanduruvaanga, namma staff will never assemble there. So there are so many variabilities. Even if you take countries, I took all the guidelines, there's no guideline on codes at all. And each of them are using their own codes. So we have to know like what is applicable to us before we adopt, and that has to be a standardized code. These are the codes which are used for any medical or surgical emergencies. For obstetrics, nobody has mentioned anywhere. They're just borrowing from medical emergencies how to call for our emergencies. But if you take the medical emergencies, code blue is a cardiorespiratory arrest. So everybody has to assemble there. Code 13 is for a pediatric medical emergency. Code red is when there's a fire in your hospital, the location has to be mentioned. Code pink when a child has been abducted and that child has to be a patient in the hospital for it to be code pink. Adha kolandengala namma kadathirchu inga kadathirchu solradella will come under code pink. Code amber when there's a visitor child which has been abducted or missing from the hospital. Code white or in your hospital or problem ஆயிடுச்சு, கூட்டம் கூடி அங்க இடிச்சு உடைக்கிறாங்க அப்படின்னா that will be code white, because you need a security emergency, a security response has to be given at that location. Code orange when there's been a spillage, hazardous material has got spilled and you need a support system there, code orange. Code green when the emergency operations plan activation, or earthquake, or there's a flooding on a place and you need an emergency team, then it's code green. All clear when everything is done well, and then overhead is for a security alert, and when there's a weather emergency, there's a code for that. What are the codes in medicine? As I said, code blue is for an adult medical emergency. Code 13 is supposed to be for a pediatric medical emergency. Code white when you need a security presence because there's going to be a problem because of a patient or a guest. Code red when there's a fire, and code pink when there's an infant or a child patient abduction. Code amber when the child is lost but who's not a patient in the hospital. Code orange when there's a spillage and you need support there. Code green when there's a natural disaster or need a mass evacuation of the place because floods, Chennai floods, it happened in so many hospitals. That time, code green, you have to evacuate the hospital. So code blue, which is for an adult medical emergency, is immediate attention is needed because there's a cardiorespiratory arrest. And any medical personnel can respond, but usually you should have teams formed for this code. Anesthetists, physicians in emergency medicine, intensive care physicians, respiratory therapists, pharmacists, nurses, all should assemble for code blue, and they should have experience in advanced life support. You need a person who knows what is adult life support, and there has to be a team leader to run the code always. The confusion in codes in obstetrics is the one which worries us. Code blue, still they call for obstetric emergencies. Code 77 is the one which the Canadian guidelines follow. Code OB is the one which is the equivalent to the code blue of adult medical emergency. It's mentioned only in the Canadian guidelines. Code OB stat is when there is no need for a neonatal resuscitation team, but you need only the obstetric team because it may be an antepartum hemorrhage where the baby has gone for a stillbirth and you're loading the resuscitation, or it can be a postpartum patient who's delivered and is having an emergency now. Pink code is used in Brazil, and that's for this equivalent to the code OB for a obstetric emergency. So this is the only guideline for codes. No other country is giving guidelines. Code 77 is for obstetric emergency. That is for a fetal emergency. That is both the mother is not affected, only the baby is affected. And there you need a code 77, and that is cord prolapse, especially or fetal bradycardia. Code OB or blue is for a cardiopulmonary compromise, and that is when there's a cardiac arrest in the mother, where you need to save both the mother and the baby. Code omega is for a massive transmission protocol activation, where you need blood to be given in emergency. So code 77 is for a fetal indication, where you need an urgent emergency delivery. It is where a fetal compromise has happened. The mother is quite comfortable, but the baby is the one which needs the emergency management. The team will include 3 obstetricians, 2 anesthetists, a neonatal resuscitation team, a labor and delivery staff, and a key nursing leadership there. Code OB is for cardiorespiratory compromise, and I said it's equivalent to code blue. Here there's both maternal and fetal compromise, and you need to do the delivery to save both the mother and the baby. Here you need clinicians, physicians, rapid response teams, anesthetists, surgeons, and lab technicians. And it should not be used when neonatal resuscitation is not desired, because don't use the staff which are not necessary at that point of time. And the potential etiology for a maternal cardiac arrest can be an anesthetic complication, can be a bleeding problem, can be a cardiovascular compromises, drugs causing anaphylactic reaction, embolism, fever, and general non-obstetric cause of cardiac arrest and hypertensive emergencies. So how will you respond to code OB, that is an obstetric emergency where both the mother and the fetus need to be saved? First is you have to anticipate a rapid respiratory decline and a difficult airway because she is a pregnant mother. You have to provide 100% oxygen as early as possible. Obtain a difficult airway card because in a pregnant patient it's not easy to intubate. And you have to page the obstetric anesthesia team stat, and they need to come rushing for an intubation or support for OB anesthesia. The second you need to be ready with is an IV therapy, and that has to be given above the abdomen. Do not give it for a lower limb access for an emergency in obstetrics. The third response, remove the fetal monitoring machines which are attached to the patients because you may need to give a defibrillation to the patient. And the fourth is a perimortem cesarean section, which is mandatory when you want to save the mother and the baby's more than 20 weeks of gestation causing a aortic aval compression. And that has to be done. You've done CPR and there's no return of spontaneous circulation. The next 4 minutes, you will be going ahead with the perimortem cesarean section. And perimortem cesarean section, remember that the vena cava and aortic compression is the one which is going to cause the problem, and that's why a manual uterine displacement is very important. There's no point in putting her in left lateral tilt that will cause problems with your CPR. So that's why you have to put her in the supine position, but manually tilt the uterus to one side so that the pressure on the vena cava on the aorta goes off. And the primary response is needed for an effective maternal circulation, which you have to bring out in the next 4 minutes, and the reversal of shock will happen if you are doing a proper CPR, and that will correlate to a better neonatal outcome. So the transport of the patient, suppose you are going to transport the patient in an emergency, CPR is less effective during a patient transport, and that's why it's better you do the perimortem cesarean section in your place and then shift the patient. That will make it much better for CPR to be continued. And suppose she's be given magnesium sulfate and she's having a toxic reaction, she has gone for a cardiac arrest because of the magnesium sulfate which you have given, stop the infusion and give her calcium chloride or calcium gluconate 10%, and that has to be given 10 ml over a period of 5 to 10 minutes. Be very careful when you are giving calcium gluconate also. The next in the code OB is the standard adult cardiorespiratory life support which you are going to give. For that, you need to give all the interventions needed as in a non-pregnant individual, like defibrillation, cardioversion, and medications. Maternal survival is the priority now, and vasopressin, remember, can cause uterine contractions, and that's why the anesthetist should also be aware. And remember the H and T's of cardiac arrest. That can be hypovolemia, hypoxia, acidosis, hydrogen ion, hypokalemia, hypoglycemia, hypothermia, and T will be toxins, cardiac tamponade, pneumothorax, tension pneumothorax, coronary and pulmonary thrombosis, and trauma. These H and T's you should remember in the etiology when you are managing even an obstetric patient. And remember, the hand position in CPR is extremely important. It has to be done as in a non-pregnant individual. There's no difference here. And always displace the uterus when the baby is about 20 weeks, because that will aid your CPR. It can be done by pushing or pulling. Pushing is with one hand, you push the uterus to one side, or you can pull with two hands on the other side and displace the uterus. And remember, the lateral bed tilt is not recommended because it makes a CPR very difficult in a pregnant patient. And the maternal position, as I said, these three things you have to remember: the hand position accuracy, the depth of compressions which you are giving, and the coronary perfusion, which will be much better in a supine position, but with manual left lateral displacement of the uterus. Remember that the responders found it much easier to perform CPR when the patient was in a supine position. And consider the possible causes of persistent arrest if you're managing her and still the mother is not recovering. There's a mnemonic for that called the BU-CHOPS, and that is bleeding, embolism, anesthetic complications, atonia of the uterus, cardiac disease, hypertension emergencies, all the other standard ACLS reasons, H and T's, abruptio placenta, placenta previa, and sepsis. Who all should respond when you're called for a code OB? It will be the obstetric resident, the consultant, the obstetric anesthetist, the resident and the consultant, the unit in charge nurse of the obstetric care unit, the NICU senior resident or nurse practitioner, the rapid response team of the NICU, the NICU charge nurse, the PCCU resident, the pediatric rapid response team, adult code blue to help you out, and the CCOT team, that is the emergency team. Other responses, when you are responding, also to switch on the infant warmer, because the baby will need resuscitation. Turn on the infant wall suction while the CPR is going on. But please ensure that someone is stationed at both locked doors. Do not provide access to everybody, because the emergency team has to rush in and rush out. And the NIC team will take over the neonatal resuscitation upon their arrival. Be very careful about all this. The other response is be firm when you're managing the crowd, because everybody will be in a panic. So for crowd control, you need a person, and no one should enter the maternal or neonatal resuscitation room who does not have a specific task when the mother's resuscitation is going on. All will need to be instructed to leave the room and the bay. And if you have extra help, and they may be needed for care of the other patients. So once the emergency is over, please thank the team, the ones who are not needed, and you can send them off and release them from the emergency. These are the codes which are used in Australia. That was the Canadian guidelines. Australia code OB is used as in Canada. That is code OB for maternal and neonatal resuscitation. OB stat only when only when the mother needs to be saved. Neonatal resuscitation is not a priority here. And the third which we are using is the massive transfusion pathway, because you need teams for this also to get the blood, because that's the most nobody will be willing to run to the blood bank and get fire scoldings from there. எப்போ பார்த்தாலும் உங்க யூனிட்ல மட்டும் blood கேட்டுக்கிட்டே இருப்பீங்க, somebody will be shouting. So keep a runner for that, so that you get the blood adequately and correctly. OB stat, when neonatal resuscitation is not needed in an emergency, but an obstetrician support is required urgently. That's why it's called as OB stat. And this should include antenatal hemorrhage with a non-viable fetus or a postpartum hemorrhage. Steps of OB stat. Here you don't need the neonatal team, so it will be the obstetric team, the resident consultant, the anesthesia team, resident consultant, and the obstetric unit charge nurse, head nurse should be there. And here also you should ensure that someone is stationed at both lock doors, and they should provide access only to the emergency teams. Maternal hemorrhage is the third code which is used. Here, a physician must call the blood bank as soon as possible to activate the massive transfusion pathway, and they should be identify themselves as an obstetric bleed, because here you will need more of cryoprecipitate and FFP to tide over the crisis. Just blood, as in other situations, may not be useful. You may need more of blood components, and as I said, a very important is a runner has to be assigned. Somebody who's fit, not like us who cannot walk. Somebody who can run to the blood bank and get the blood as quick as possible. And it is named as code Omega in Canada when you want to activate the massive transfusion protocol. Brazil, it's PIN code, and that's for abruption, umbilical cord prolapse, uterine rupture, and acute fetal distress. So the next code which we use for the urgency of cesarean birth. Suppose the cesarean has to be done within half an hour, within 45 minutes, within an hour. All that is also coded as emergency codes. Category 1 according to NICE guidelines is when there's an immediate threat to the life of the women as well as the fetus. There can be a uterine rupture, there can be a major placental abruption, there can be a cord prolapse, fetal hypoxia, persistent fetal bradycardia. All that comes in category 1 emergency cesarean section, and that is very urgent. The second is category 2, where there's an urgency but there's no life compromise for the mother or the baby. Category 3 is there's no compromise but an early birth is advisable. Category 4 is an elective cesarean where you can do it at your wish of the women or the healthcare provider. So these are the codes which is used. The red code is for one where you need to do the cesarean section in the next 30 minutes. And it's a life-threatening condition for the mother and the baby, and that is a very urgent cesarean section. Orange is for the urgent cesarean section, and that can be done within 75 minutes, and that is related to a maternal or fetal compromise, but it is not immediately life-threatening. Green is for a non-urgent cesarean section, and there's no maternal or fetal compromise. Category 4 is the elective cesarean sections. And they have said that a decision to delivery interval, if it's less than 30 minutes, they have said it causes less fetal hypoxia. And that's why this 30 minutes is stuck on in so many places. But there's actually evidence that you can do it in a little longer period of time. You need not like panic, have a heart attack of yourself before you do the cesarean section. You can actually wait a little bit time. And according to NICE 2023, they said if you do an emergency section within 75 minutes, that actually gives a good, significantly better outcome. And American College, they have not proposed any specific time limit. They have just said, take the whatever is available in your place, like local circumstances, the logistics of calling for an anesthetist, senior obstetrician, all that has to work into your like the fastness of doing a cesarean section. But RCOG says delay of 75 minutes for an urgent cesarean section is okay, but for a very urgent condition, 30 minutes time interval is quite good. And in Germany, they said you have to do it in 20 minutes cesarean section. France has no guidelines, but there's a study which said 15 minutes is advisable for doing a very urgent cesarean section. I don't know where they'll get the anesthetist because our anesthetists don't turn up so quickly. But I'm finishing. So I'd like to finish with this committee opinion of American College. The availability of anesthesia and surgical personnel should be sought to permit the start of a cesarean delivery within 30 minutes. It's not only dependent on us. You need a team to help you out. So the take-home messages from my talk will be, for a cardiac arrest, that is a maternal and a fetal compromise which is happening, call for a code OB. For a maternal compromise where the baby is not viable or there's a postpartum hemorrhage, call for a code OB stat. Code 71 is for a fetal compromise where the maternal compromise is not there, and it is usually for cord prolapse or fetal bradycardia. Code Omega, according to the Canadian guidelines, is for activating massive transfusion protocol. and codes will be used for indicating the rapid response needed of performing emergency cesarean sections. Red for very urgent, orange for urgent, and green for non-urgent. Thank you so much, Chakravarti sir, for the opportunity. Dr. Umaya and the Kanjivaram Society. Thank you so much.